Great, thank you very much. Hi, everybody. And also, I was hoping that the two nurses that have been doing super extra preparation for this could also come on at this point and introduce themselves as well. That would be wonderful. I know does everybody know each other already?
Most people know each other, so I'm going to go ahead and unmute Blondine and Jamie. And they can introduce themselves and, yeah, go ahead.
Great, thank you. So this is Patty. I'm a family nurse practitioner. I've done pretty much, for most of the last 36, 37 years, I've done pretty much exclusively sexual and reproductive health, with exception actually of about 8 or 9 years when I also did primary care. But even during the time when I was doing primary care, I was still doing a specialty procedure clinic with IUDs and implants and stuff at the local public health clinic, so the county where I lived. So I've really done sexual and reproductive health primarily throughout my career, and I've been focused mostly on family planning, sexuality, and pretty much throughout everything that I've done, a lot of focus on counseling. And I know just, maybe Blondine and Jamie are exceptions, but speaking to them, I realized that potentially your group has a tremendous amount of background in counseling, and that's really gratifying because this framework that I'm going to talk to you about today really relies on somebody being able to listen to their patient and being able to respond in a genuine way to having really listened and really heard what the person's saying, who they are, what they're about. So I'm really excited to be working with you folks today. I'm one of the senior authors on the book Contraceptive Technology, and I don't know if you've read that or know about it. It's in our 21st edition right now. We just came out with it last year. I wrote a brand new chapter that had never been in the book before about contraception counseling and reproductive goals counseling, which is, we're going to focus on both today, with a little bit more of an emphasis on reproductive goals. But the chapter, if you want to get into more depth, is I think pretty comprehensive. It also has some theory, but it's pretty approachable. And the reason I bring up the book, in addition to the fact that I love that I'm involved with it and that it's a great reference, is that I do think of all the materials that are out there for you to use as kind of background, textbooky kind of background to contraception, contraceptive technology is probably the most comprehensive and also the most approachable at the same time. And it is very up to date, as I said, because we just had our 21st edition come out at the end of last year. So if that's something that you can swing, then that's a really nice reference for you. And I also did we just updated the chapter on sexuality and contraception, if you have questions and interest in that, questions about that. So what we're going to do, I would love now if potentially Jamie and Blondine could introduce themselves, although, as I said, maybe everybody knows each other, and then we'll get started. And I'd like Jamie and Blondine to be, I've asked them to sort of practice this even more maybe than some of the other folks on the call may have practiced, and to give us some of their feedback. And we're also going to show you a little bit about how it works. But maybe Jamie, you want to start?
Sure. Hi, this is Jamie. I'm a registered nurse at a Miller Children's Hospital. And just a little about me is I've been in the mother-baby field for the past 6 years, doing labor delivery, home health, and home birthing, and then Welcome Baby. And I'm really excited to do this presentation with Patty. Thank you.
Thank you. And Blondine?
Hi, good morning. My name is Blondine. I'm the nurse for the Welcome Baby program. And I've been doing home visits for quite a while now. And prior to Welcome Baby, I used to do pregnant parenting teams exclusively.
Great. Well, thank you. And I'm just wondering, from those of you who are on the call, if you could, into the chat box, if you could just give us a sense of whether you've been, whether you did actually print out the job aids, whether you've played around with them a little bit, any experiences that you've had. And I would love if somebody has something, you put in the chat box and there's something to share, we can, at that point, unmute you and you can tell us what your experiences have been. The other question I have, in addition to those job aids, is whether anybody's had the opportunity to download that app. And if so, whether that's been valuable for you. That's the other thing I'd sort of like to know. So I'm going to get started. We're going to look at some slides here, and I'm just going to sort of talk at you for a minute, and then we'll see, first of all, about Blondine and Jamie's feedback and their involvement in having practiced, and then we'll do a little modeling for you. So these are our sort of broad objectives. We'd like to have you address reproductive goals and contraceptive preferences with everybody, pretty much anybody who, even if they're not themselves capable of getting pregnant, like if you have an opportunity of interfacing with somebody who does not actually have pregnancy capacity, but potentially could have create pregnancy with someone else, that's also somebody that you'd like to talk to about their reproductive goals potentially. And then, as I mentioned earlier, really being able to have some skill and being able to ask questions in a patient-centered way, and also be able to use counseling skills when you do that is really kind of what we're going for here. And I will say, we're not, with this framework that I'm introducing to you, we're not really thinking about this as you need to have a bunch of skill in order to be able to do it. It's really supposed to be helping you to gain those skills. Because if everything's going well, the framework is going to encourage you to listen, which I think anyone who has focused on listening, and I'm sure all of us on this call probably have, because you're nurses, and that's really a lot of what we learn how to do. It's challenging. It's hard to learn. It's hard to listen. And so hopefully asking questions that are both open-ended but focused on something that's the substance of the conversation about, something substantive, like about their reproductive goals or about contraception. In other words, not an open-ended question just about their life, but a focused question, but that is open-ended, allows you to see the individual. So hopefully that's sort of the goal here, is that we're going to be facilitating with this framework, facilitating listening. So this is the app that I asked you to download. It's from the CDC, and their MMWR, their Morbidity and Mortality Weekly Report, is where they have their white papers published. This was published in 2016. They do updates periodically, but as I think if you've read the email that Malika sent around, then it's about this particular guideline, and it's about safety. And it's really, there's lots of guidelines about all kinds of stuff, but when we talk about contraception, there's really only one set of guidelines, and every professional organization signs off on the same set of guidelines. And these guidelines come from CDC. They were originally based, believe it or not, on World Health Organization guidelines, but they were adapted for the US, and then they were continually updated, and they are specifically the specific guideline is categories of safety. So if you look at these categories here, basically the guideline tells you, for your patient who has some medical condition or personal characteristic that may make using a particular birth control method unsafe, is it safe or isn't it safe? I don't know. My patient has migraine with aura. Is it safe for my patient to use birth control pills that have estrogen in them? Well, no. That would make it a 4. The condition represents an unacceptable health risk. That's the bottom bar here. The 4 is a red. So you think about anything that the evidence shows use of a birth control method for that particular individual will be unsafe, they give it a 4. So it's very cookbook in that way, which I appreciate. And then they'll also give you a footnote explaining why. And then the top 2 ones and 2s, are actually safe and fine to use. And there's actually not a preference here. It makes it, the way this is numbered, it makes it seem like 1s are safer for your patient than 2s. But that's not really the way you want to think about it. You want to think about it that anything with a green is safe. And what is most safe, and you probably all know this, the safest birth control method is the most effective birth control method, because at the end of the day, birth control is safe. Contraception is safer than pregnancy, really every time out, except for if the contraceptive method is in a category 4, according to this guideline. But if it's not a 4, it's safer than pregnancy. So that brings us to the pink line, which all of us believe should be yellow for proceed with caution. But CDC gave it a pink, sort of a light red. So it's not a contraindication. It's not an absolute don't do it. It's still safer than pregnancy. But if there's a 1 or a 2 that the patient will use and that is very effective, that's a safer choice. But when you think about it, if the 3 that the patient could be using is something that is highly effective, and the only other choices the person has are what are called third-tier methods, things like condoms and withdrawal and spermicides and natural, fertility awareness-based methods. If those methods are the only thing available to the person that are a 1 or a 2, that's not safer than a 3 that's highly effective. So sometimes, depending if you have a patient that's particularly complex medically or has a medical condition that's particularly serious, they actually probably will need to be using a method that the CDC categorizes as a 3. But that's safer for them than a wing and a prayer, which is what otherwise a lot of the providers that you're dealing with may be doing. So sometimes what you're going to be doing is using this tool to show patients why a particular method is not okay for them. For example, they are 36, they smoke, and they want to continue using their birth control that has estrogen in it. This categorization of 4 shows them why they can't. But it's also used, you can also use it, and Blondine was mentioning this, and I think Jamie was mentioning this, that the providers that you work with sometimes are not aware of what is and what isn't safe, and sometimes they're sort of going on some old myths about what's safe, because there's certainly been a lot of change in this field over the last 10 years. So that's another way you can use this tool, is that you can share this with patients, you could share it with providers, you could tell the patient about this and they could share it with the provider. We could talk about that too, but there's I'd just like you to know that this tool exists, because it is really the only final word on whether something is or isn't safe. There's also in the app, if you've downloaded it, and perhaps by a show of hands or maybe in the chat box, can you let us know if you have downloaded it and have used it? Because I just, would like to know whether everybody has already given it a whirl, and then we can get some actual feedback about what you think. So you've noticed, if you did download it and you have been using it, that it's actually a dual 2-in-1 guideline. So the app has associated with it both the medical eligibility criteria that I just talked to you about, and also this guideline called the US SPR, the Selected Practice Recommendations. And I don't really think that you need to be, completely familiar with everything the SPR has to offer, but it's something that's really easy to use and really simple to read. And if you have a question about, for example, how long somebody needs to use backup after starting a birth control method, or maybe your patient has developed an infection when they have an IUD in place, it tells you how to manage PID with an IUD in place. And I understand that you're not providers writing prescriptions, but it really is pretty helpful. So that's kind of optional, but it's there for you. And it's also, again, as with the medical eligibility criteria, there really isn't another guideline like it. This is really the only one we have. So let's talk about also, very briefly, I'm not going to go into them, but the job aids that I had asked you to download and to laminate. So this is just a flow chart, and hopefully you've had a chance to use it. And it's basically saying, when you ask the questions, this is kind of the algorithm that you go down, and it's a very loose algorithm. I don't want you to think that this is in any way prescribed. What's prescribed about this is the actual words, so that when you're going to ask about reproductive goals, you would say, do you think you might like to have more children at some point? And I'm saying more because you folks, I think everybody has had at least a child, or they wouldn't be in your program. And so then it just shows you how to sort of move down the algorithm. And on the other side of it is some counseling skills. So these are just for you to kind of have at your disposal to look at and read, hopefully. And I'm really curious to hear feedback. Hopefully you find these valuable, useful, without having to be very time intensive. The goal of these job aids was to save you time. And then this is the other job aid that's essentially for the questions, and that's just a palm-sized, sort of postcard-sized job aid with exactly the same questions, but in a more abbreviated format. So this might be something, and here's the other side of it, this might be something that you'll enjoy having in your pocket, which makes it a little easier. And this isn't meant for you to just read verbatim off of it for the patient per se. It's for you to have at your fingertips, very easy to look at what those actual verbatim questions are. And then finally, this one's probably not going to be one you're going to use a whole lot, but so that you know it's there and it's part of the set of job aids. This is for preconception counseling. And here's the front and here's the back. I would suggest, and I don't know whether you ever do this, I should have asked Jamie and Blondine, but do you ever carry with you examples of the different birth control methods? Do you carry an effectiveness chart, just like a little 8x11 effectiveness chart, little anatomy images with you? And then definitely all of the different, here's what a effectiveness chart would look like. This is from Bedsider. These are very easy to just go onto the website, download them, keep them in your bag, and just have them there to sort of orient a patient's thinking while you're talking with them. These are all the various methods you might want to consider having demo units for, just so that people can see what it is you're talking about. And I do recommend having anatomy images also, just print it out, just in your bag. And perhaps you already do. I'm curious about that. So I want to do a couple of slides about kind of the big idea about the concept of pregnancy intention. These are somewhat theoretical, but it's also talking a little bit about research that's qualitative about our patients and how they view their own reproductive goals, if you will, or their reproductive preferences, their reproductive desires. So let's talk about that just a little bit, and then Blondine and Jamie, I'm going to ask you guys to jump in at that point as soon as we finish with a few of these sort of more theoretical slides. And the reason that I like to think about this theoretically is that I believe that most of us, if asked, and if we haven't thought pretty deeply about it, would say that it's really better if everybody plans their pregnancies, and that that's kind of the goal. And that if you're going to plan a pregnancy, you should do it in a situation where you have, at least you've got two adult partners, a couple that are both invested and have decided to do this together, and that their finances are in order, and that they're ready to do this. They have a place to put this baby or babies, and everybody's all ready. So I think that's what most people would think about as, when you have all your ducks in a row, then you plan a pregnancy. That's kind of the what I'm going to call the dominant paradigm. That's kind of what we all ascribe to as being the ideal. So whether that is ideal or not is irrelevant. What is important is to think about the people that we actually talk to and what their reality really is. So I think that's the reason for the theory that I'm going to talk about. So what about people's thinking or feelings about their reproduction become important? And I'll say, for example, asking somebody who has never had a child, how many children do you want, is maybe an interesting question for a sort of a social event. But in terms of clinical relevance, when you have your patients who are postpartum, yeah, it's important to find out if they want to have another one anytime soon or not anytime soon. That's very important. But is it important to think about, to ask your patient how many in general? That's a very big planning concept. How many children do you want in your life? So is that really important? And I would say, let's think specifically about which things we ask our patients will give us information that we really could use today to help them get what they want. So the theory about that is plan. Hello?
Yes.
I think that's, I'm going to assume that's background. So the concept with this is that someone's plans around getting pregnant or having a child, their intention, their desire, and their feelings may or may not be in any way aligned. These are actually different concepts. A person can be very actively planning a pregnancy and absolutely not want one. They can feel incredibly scared and yet be planning. They could be planning very much not to, but very much they would want one, a baby or a child. There's so many different ways this can play out, but I think it's important from a top-level theoretical framework to think about separating these, okay? Some of these concepts may or may not be meaningful for any one of your given patients. So definitions, plans is a specific first decision about when and if to get actually do something concrete, which is getting pregnant or adopting or doing something to actually make the desire for the child a plan. You have to have a formulation of an action, or at least a plan for an action. You have to have sort of the idea, the steps put in place in your mind. An intention is more of a timing-based idea about when you want to get pregnant. It can include desire, wanting, but it's about sort of a general time frame. Then there's feelings, which are really completely about the emotional orientation towards pregnancy. And again, somebody could very much not be able to have a child at this time and yet very much want one. A person's desire is the strength of the inclination to get pregnant or avoid. So this is where basically think about this as kind of throwing want into the equation and throwing feelings into the equation, and what you're ending up with is desire. It's a very non-specific term, but it generally means the answer to the final path question. How important is it to you to prevent pregnancy? And by the same token, you could say, how important is it to you to get pregnant? So that's kind of what the desire is about. So I think all of these matter very little in terms of parsing out the difference, because what really matters to your patient and really to every human is whether and to what extent a pregnancy is acceptable. Whether that happens before the person gets pregnant or after, it's really about to what level is it acceptable. And what that means is when you take all of these other components into account and you put them into a big pot and you stir it up, the thing that will come to the top to decide whether this person is going to get pregnant or not get pregnant, to decide whether this person continues a pregnancy or doesn't continue a pregnancy, and to decide whether that person actually rears that child or not. This is all about acceptability. So that's where I think if you're going to think about one word that talks about someone's orientation towards pregnancy, acceptability is a really nice place to start. This study by Sonia Barrero talks about the conceptual framework on which somebody may or may not plan a pregnancy, quote unquote plan. So think about that word plan. I really want to encourage you not to use the word with your patients. Except if the patient uses the word. So if the patient's a big planner and the person's using the word plan all the time, be my guest. But otherwise, I would be really cautious and watch your language, because you probably use it all the time. We're probably all big planners. I think most nurses are. So I think this is something you're going to have to look at in your language if you're interested in changing this. I know it's really hard for most people. It certainly has been for me. But the reason is because the word plan is not without meaning. It has a specific meaning. So in this study that Sonia did, this was with low-income women in Pittsburgh, and the women that were in this study had all been pregnant or were currently pregnant. So the concept of them having planned or not planned that index pregnancy was very recent in most cases. So they had a pretty clear idea of what plan did mean for them. And I think most of us have our own definition of plan. I think when I talked about people should have their finances in order and be in a stable relationship with another adult, married usually, that's sort of the dominant paradigm, but it also, by the way, is precisely the same paradigm as the women in this study, as well as in Abigail Aiken's earlier study in 2013. Really came up with pretty clearly, pretty much across the board, that the people in this study did consider planning to be a very deliberate act in which both partners discuss and reach consensus about the timing of pregnancy and then take steps to prepare for a potential pregnancy. And then, very importantly, it includes getting your finances in order. And nearly all the women in this study had strong feelings about these ideal circumstances. And I mean, when we say that, they had judgment about people that were planning a pregnancy. One woman had a quote that a friend of hers was engaged They both were employed, the two people who were engaged. They were engaged, they were employed, but they were not yet married, and they were planning a pregnancy. And she was very judgmental about that they should not be planning before they were actually married. Very interestingly, that even though they had strong feelings about these ideal circumstances, they themselves were actually not having those situations. They were not having relationship stability or financial stability. So did that mean these women did not get pregnant? No, obviously that did not mean they didn't get pregnant. They did get pregnant. They just didn't plan it. So that's the really important piece to take away from this, is that people will continue to reproduce and be happy to be doing that. Not that it's a problem. We're not problematizing that. It's that people will reproduce, and in some cases, many cases perhaps, planning has nothing to do with it. It's just not irrelevant. So then we come to the concept of, we do want people to space their births, and we do want people to have preconception care, and we do want people to use folic acid before they get pregnant. We want all these things for our patients. Those do have really important health outcomes. So the way to deal with that is to talk to your patient where they are and not talk about planning. What you're doing is being prepared, but you're not planning. So that's sort of the big idea behind this. So because these sorts of planning and intention concepts are not happening, these decisions about the acceptability of a pregnancy in this study were often determined after the pregnancy already occurred. This is undoubtedly what you're seeing with your patients as well. But remember that that did not mean that that wasn't a happy-making pregnancy for them. Just because something was not planned really doesn't have to have much to do with whether or not that's going to be the best thing that ever happened to that person. So I just think it's important to realize that your patients do have agency over their reproduction, and they do have an interest in having autonomy about their reproduction, but they don't necessarily resonate with that word plan. So I generally think it's a good idea just to not talk about it at all. And this is the plan, the word plan. So this is the final theoretical slide, and after this we're going to talk more concretely. But let's think about this as two axes. So one of them is on the left is the strength of desire for pregnancy. So how strongly does somebody want to become pregnant? And then on the other axis is the strength of desire to avoid pregnancy. So let's think about this. If we think about somebody who really wants to be pregnant and has really no desire to avoid pregnancy, they would be all the way up here. Okay, so that would be a person who desires pregnancy. And then the person who really strongly is trying to avoid pregnancy, they have a very strong desire to avoid pregnancy, and they don't have any desire to become pregnant, they would be over here. They would be wanting to avoid pregnancy. But you know what? Not a lot of people live very firmly in one of those two little circles. So then there's the people who potentially are up here. They have a very strong desire for pregnancy, and they have a very strong desire to avoid pregnancy. Perhaps you've met these people. They're called ambivalent. And this is something that we all probably experience at some point in our reproductive lives to some degree or other. Some people all the time, their entire reproductive lives, and some people just occasionally when they're having, terror the night that they're having unprotected sex in order to get pregnant for the first time. But there's all kinds of ways that ambivalence shows up. So sometimes ambivalence means that you are holding two mutually exclusive goals or desires at one time. And sometimes it just means that, and I'm going to argue that this is much more often, sometimes what it means is that your patient is motivated to do something very strongly, and they also have other motivators pulling them in the opposite direction. But usually it's not a long list of things that are pulling them one direction or another. Usually there's just one or two, perhaps at most, obstacles holding them back from being able to actually achieve whichever one of those two things they really want. So somebody who's ambivalent generally has motivators in both sides and towards both ends of what it is they're ambivalent about. And it's helpful if we can help them see that so that they can decide whether it's an issue for them or not, and whether it's something that they would like to actually learn more information about in order to make a choice, or to perhaps behave in a way that's more likely to get them to their goal. And instead of continuing to have unprotected sex, perhaps they're going to use some contraception so that they are going to have their next child at a time when they might be clearly saying that's closer to what they want, as opposed to their ambivalence is saying, yeah, but I'd kind of like to get pregnant now, so I'm just not going to really use any birth control. I could get into about 3 hours of conversation about ambivalence, but let's just say that in general, it's not necessarily a problem, but you would like to be able to find out from a given patient to what extent there are different things working on them at a given moment, so that you can help them figure out whether that is or isn't a problem for them and what they want to do about it. And then the one area that we haven't talked about that is probably not uncommon at all, but that frequently gets missed, is this little category down here. So somebody who doesn't have much of a desire to be pregnant, and they really don't have much of a desire to avoid pregnancy. Perhaps you've met this person. They're indifferent, actually, and that's a word you might not have ever applied in this context. They're indifferent, meaning if it happens, it happens. That's a very, very common stance for people, either because of religion or because of lack of autonomy in their life, or because this is how they like to live their life, is that they're open to whatever happens. There's a million reasons why somebody might say if it happens, it happens, but this is not a small category. So then we want to find out what should be the focus of counseling conversations, therefore, that are aimed to help people to achieve their reproductive desires. I'm going to say that everything we talk about today is really designed to help people to make choices that are healthy, and that at the bottom of it all are consistent with their own goals. And that's really our goal, is to be able to help someone figure out what their goals are and help them get it. So if we want to do that, if we want to help them achieve their reproductive desires, how do we do that in a counseling conversation? And that's where shared decision making comes in. Perhaps you've all heard of it. So what I'd like is if Jamie and Blondine can talk a little bit, we're not going to model quite yet, but I'd like to hear each of their experiences of having practiced with some of the framework that we're talking about today. So I'll just choose. Blondine, can you start?
Yes. So
tell us how it's been for you.
Well, for some of the question, like how important is it to you to prevent pregnancy? I have to usually repeat the question 3 times, either in Spanish or in English. It seems like it doesn't click. Like, what do you mean by that? As opposed to asking, do you want another child soon? Then
so asking that last question is, okay.
So it seems
it's
like
interesting because what I was going to say is that personalizing the last question is quite important, and that's one of those things where if you just see the job aid, sometimes it's not quite clear that personalizing it is really important part of it. So how important is it to you to prevent pregnancy until, like, let's say they say they want to wait until their baby's 3. How important is it to you to wait before you have another child until Jamie is 3? Jamie's not the baby, but so in other words, personalizing. I don't know if did you try that at all, Blondine?
Yeah, I avoided important. I just said, so when do you think you would like another child? It seems like the word important throws them off, but also on the, do you have a sense of what is important to you about your birth control method? I have to rephrase this. I'm like, what do you mean what's important?
So was it the important about birth control question that was difficult, or was it the how important is it to you to prevent pregnancy, or both?
It's like the phrasing of both questions. It seems like some of them answer right away, but I say like most of them, I have to rephrase it. Like, what do you mean important? What do you mean important about my birth control method? I don't even know what I'm going to use. So that it's the phrasing that I have to rephrase, which is okay to rephrase.
Oh, it certainly is. It certainly is. I'm wondering what it is about we're going to get into modeling in a little while, so I think we'll have an opportunity to unearth what might be going on with that. Jamie, do you have anything to add to that right now with what Blondine said, and also how was your experience with it so far?
Yeah, so same with Blondine. It definitely took me a couple tries to normalize the language into how I ask questions, because just like we've mentioned previously, everyone has their own way of how they talk to clients and patients. And so being able to take out the sheet and use the questions verbatim was just something to get used to. But once I got the hang of it, just like with Blondine, when they did ask for clarification or to rephrase a question, it would just be examples of like when they would say, what do you mean? What options do you like with your birth control? I would have to provide them different options to give them examples to see, or from previous experience from what they were telling me, if I knew they were very religious or if I knew they had health concerns, I would kind of throw in and personalize it towards them specifically so they would be able to answer those questions.
So, for example, if you said, do you have a sense of what's important to you in your birth control, and they said, what do you mean? You would say things like, well, for example, some birth control methods are better at this or that. I mean, is that the sort of thing you're talking about?
Yeah, so it would definitely be from something they've disclosed openly during talking. So a lot of people pretty openly discuss like, oh, I don't really like hormones, or they'll say things like that. So I would ask them to emphasize during those questions to be like, is there anything else other than hormones you don't like? Do you not prefer having anything inside your body? You know, those kind of questions to kind of probe them for what they really are looking for, or to really get down to the specifics of what they actually like or don't like about birth control.
That's great. And I think also asking those questions, those follow-up questions, when you said you're individualizing them, is also really important. Like if you see somebody who you believe from a prior part of the conversation may be experiencing reproductive coercion, where their partner wants them to get pregnant and they don't want to, you know, you could say things like, yeah, for example, some methods of birth control are easier to hide than others. You know, for somebody that you think that might. So I do want to circle back with that question though when we get to those questions, because I think that clarifying some of the issues that have come up for you, I think, is really valuable for folks. And I'm going to look over here. I'm looking over here with the chat box to see if anybody has said. Oh, somebody said several clients believe that if they've been using birth control for a long period of time, it will take them longer to get pregnant in the future. Is this a myth? The only birth control, this is a great question, the only birth control method that creates any delay in return to fertility is the injection. Everything else does not have any delay in return to fertility associated with it, and actually the longer you use it, it doesn't have any different impact than if you use it for a short time. So this question has sort of two parts. One, does birth control affect my fertility or my ability to get pregnant in the future? And the other question is it when I use it longer, does that make it more difficult? And the answer to both of those is no, unless it's the injection. But this is a very common thing that patients will be concerned about. And I think it's very important to find out exactly whenever something like that comes up, where there's like this misconception or they have misinformation of some kind. It's important to start with something positive, and we're going to talk about this later. Start with something, yes, like I can see how that's concerning to you, or I hear that a lot, or I can see how you would think that. So something positive, and then answer the question so that they're feeling like you're not just correcting them. Just looking to see if there's any other. Oh, so she said they downloaded them and played with it a little bit, trying to figure out how to navigate. Okay, fair enough. Patients say they don't plan to get pregnant, but if it happens, it happens. Right, and so the person who just said that in the chat box, that's why we don't want to have that plan word in there, and we definitely want to use the questions for path verbatim, because that's more likely to get actually real intention on somebody's part. What really matters to them, what really is and isn't acceptable to them. This is just a shared decision-making, sort of breaking it down to what we're contributing and what patients are contributing. And I just want to point out that on the side of patient contribution, where somebody is contributing their values, which is what Jamie was talking about, where knowing a person's, for example, their religious background or their family background, their preferences. So do they want something where they get a period or something where they don't get a period? Do they want something where their menstrual periods are less painful? Do they want something to treat their acne? Do they want something that they never have to think about? And then their goals, that's what we're talking about with reproductive questions. And their past experiences is what both of you were talking about, which is what patients are bringing to this conversation, both in terms of their experience with contraception and their experience with us, with healthcare. Maybe they had bad experiences, traumatic experiences with healthcare, and they are very wary. Perhaps their friends of theirs have been hurt in the hands of medicine in some way or another, and perhaps they've had past experiences of trauma of one kind or another. Lots of different aspects of how their past experiences may be affecting the conversation that we're having, but that's what they're bringing, and that's what's important, not our past experiences or our goals or our preferences or our values. What we're contributing is to help them clarify what it is that's important to them, and that's what we're doing when we ask the past questions, and that's what we're doing when we ask the contraception questions, and then to give them the information that's relevant specifically to them. So not telling them information that's kind of generic or information that's relevant to other people but not to them particularly today. Always save your time, because I know you don't have all the time in the world for these visits, by picking the information that is really relevant to that person that day. And in fact, finding the information that you think is the most important for that person to know, because it can't take in a lot of information anyway. Nobody can take in that much information all at once. In fact, this call, this length of time already, you may already experience, you're finding yourself a little bit saturated. That's probably what your patient's experiencing fairly early in the conversation as well. That's probably just a good example. Because your job not only is to help them clarify what they want and to help them get it, it's to help them have the information they need to make decisions and to get what they want about their reproductive goals, which means you have to know what information they need and also help them assimilate that information. Not such an easy job always. Does it take longer? I'm just going to say this really quickly. If you do give information that's not relevant, it takes up a lot of time. And then the patient also doesn't really get to take in as much information as they would if you gave them less information. And therefore, you're going to have to repeat later. That's going to also take up time. If your patient, if there is not good rapport, every single person on this call, I am fairly certain, knows this very well, that if there's not a good rapport, there's not good trust, the patient may feel some resistance, and that is what takes the most time of everything. The thing that takes the most time is if your patient's having a difficult time trusting you. And then here's the real reason why I want you to see this slide, is that it's about paraphrasing. And I know we've all learned it in nursing school, but paraphrasing is the way that you can, in a patient-centered way, keep control of the interview for the entire time. So here's the past questions, and I want to go through them a little bit, and then I want to practice with Blondine and practice with Jamie. So we're going to do it for you. We're going to show you. So the questions are very simply, and when I say verbatim, I do want to encourage you to try these questions verbatim, the only adaptation being personalizing them. So in other words, not changing, do you think you might like to have more children, at some point, to when do you think you'd like to have another child, because the second question is meant to follow the first, so that you wouldn't ask when do you think that might be until you had established that the person in fact did want additional children. And then the when do you think that might be is meant to be super open-ended. It's not meant to be, well, are you talking about 18 months or 2 years? Are you talking about 12 months or are you talking about 18 months? It's not supposed to be really drilling down to make somebody have to commit, because you all know this as well as anyone, people's reproductive intention or plans are not necessarily realized in real life. Somebody may say to you 18 months, but it's actually going to be 12. Somebody may say to you 18 months, and it's actually 3 years. For a variety of reasons, all of which many of which we've touched on, but there's more. It's just a very complicated thing about when you end up having a kid. But the when do you think that might be is not designed to nail down something specific. It's designed to give you the opportunity to talk about optimal birth spacing, to give the opportunity to get a sense of what their frame is for their own life going forward, because sometimes the answer is not in time. Sometimes the answer is in life events. Yeah, I love this baby so much, but before I have another one, I'd really like to be married. So that's not about timing, right? That's about life event. Or yeah, I really want to wait till I'm going back to school, and I want to wait until I'm out before I have another child. Things like that. That's timing that isn't actual time. It's about life events. And that's what you want. That's one of the reasons for asking these questions very verbatim, is that you would like to have the person responding to the question interpret it. So you don't want to say a specific time frame, because you don't want to say to them, well, do you want to do this in the next 18 months? Because you want to let them interpret time. When do you think that might be? You want them to interpret that for themselves. Doesn't mean it's the end of the conversation. It's just the beginning of the conversation. We'll talk about this, how important it is to you to prevent pregnancy. Until then, I just right now want to point out one thing, which is, no, two things. One, how important it is still something that needs to be asked, even if the person said, if you said, do you think you might like to have more children at some point, and the person said, absolutely not, I am done. You still need to say, how important is it to you to prevent pregnancy? Because just because they said they're completely done doesn't mean that they actually care that much one way or the other. They may say, I'm completely done, and if it happens, it happens, right? That's a very different person than says, I'm absolutely done, and if I got pregnant, it would be the worst thing in the world for me. Those are two very different people. And so you do need to still ask that last question, even if the answer to the first one was no. The other thing about the how important is the in parentheses, until then, is great for teens. So the person says, if you say, do you think you might like to have more children at some point? And the teenager says, yeah, absolutely, I'd like to have another child, whatever the person says. You don't even have to ask a timing question. You can just say, how important is it to you to prevent pregnancy until then? You can just say until then, unless the person has given you an idea of when that, like if the teen says, well, I'd like to be out of school first. I'd like to graduate from high school. How important is it to you to prevent pregnancy until you've graduated from high school? So in other words, you're personalizing it. But with a teen, you can just say until then. The other time when you say until then is if the person hasn't given you any information. You say, do you think you might like to have more children at some point? Yes. When do you think that might be? Well, probably in a couple of years. How important is it to prevent pregnancy until then? Or you could say in a couple of years, but you could use until then. That was probably a bad example, I'm sorry. But you can use until then when you don't have other information. Otherwise, it's always good to put in personalized information. And the reason for asking these is so that you do, if you look at the far left, so that you do have a sense of how acceptable a pregnancy would be. And that's really where you're looking. These questions are helping you to figure out that acceptability question, right? Because if it's really, really important to somebody not to get pregnant, and they have clearly expressed to you that it is not acceptable, then you will have a different way of responding to them when you're talking about contraception than if they say, well, yeah, I'm open to it. Because if they are saying it's absolutely critically important that they not get pregnant, one of the most important things, then you're going to definitely be looking at methods that are in the top, at least the top 2 tiers, if not the top tier of effectiveness. So if the person says yes to the first question and there's any answer that indicates no time soon, so this is really relevant to your patients. You say, do you think you might like to have more children at some point? I'm going to assume that the majority of your patients are going to be responding, and Blondine and Jamie both said that they thought that this was true when we spoke earlier on the phone earlier, that you don't have a lot of patients saying, yeah, I'd like to get pregnant now again, or I'd like to get pregnant soon. The exception to this, obvious patients that have been struggling with fertility, they may actually be looking at a fairly quick turnaround for another pregnancy, in which case preconception care conversations are very appropriate. In general, though, you can assume that if somebody gives you an answer that makes it seem like they're not looking to get pregnant anytime soon, you don't have to press any further. You can just ask, how important is it to you to prevent pregnancy until then? So for example, she says, you say, do you think you might like to have another child someday? And she says, yes, I definitely want to have another one. I'm pretty traditional, and family is one of the most important things in my life. I want to be married before I have any more kids, which I don't see happening anytime soon. So this is an example of somebody who says yes to the first question, which means they still need the last question asked. But do they need a question, when do you think that might be? I would say no, right? I don't see that happening anytime soon. So you've already got the answer to that question, right? So since the timing-based question has already been answered, you can just skip the when do you think that might be and go directly to an H question, a how important question. Now let's ask, though, for this patient, how are you going to individualize that how important? If the person had said, when I'm out of school, you could say, how important is it to you to prevent pregnancy until you're out of school? If the person had said, and I don't want to have another child until my partner gets back, how important is it to you to prevent pregnancy until your partner gets back? Which, by the way, if you find that seeming like there's an error there, think about it for a minute, because people do have sex with people even when their partner is out of town, or even when their partner is in jail, or even when their partner is like working out of the country for some period of time. So don't always assume just because somebody's partner's out of town that they're not potentially at risk of getting pregnant. So if you don't have any other information, you use until then. But with this patient, we have information. We have information that she said that this person said they would like to be pregnant. Excuse me, that person said they would like to be married before they have another baby. So we're going to personalize that question. But with teens, remember I said you can leave off the timing-based question altogether. You can just go straight from when the person says, yes, I'd like to have more children at some point, you can just go straight to how important is it to you to prevent pregnancy until then. And I would say for a lot of your patients, you probably could do that, not just teens. But for this woman, she said, I'd like to be married. So you're going to reflect back what she said, and you'll say, how important is it to you to prevent pregnancy until you're married? So that, I don't know, Blondine, if that helps any to think about personalizing that H question, that how important question it's really important. And then will you offer to discuss preconception care in this case? Okay, because her response, right, we said, here's what we said. We said, how important is it to you to prevent pregnancy until you're married? And she said, it's important, but if it happens, it wouldn't be the worst thing in the world. I'm a grown woman. Okay, so would you offer to discuss preconception care with this patient? What do you guys think? Blondine and Jamie, are you going to offer preconception care for this person?
Yes.
Yeah?
Yeah, definitely.
Yeah. Great. So there you see where the subtlety starts to happen, right? This is not somebody who says, I'd like to get pregnant, and so you're saying, here's your prenatal vitamins. Okay, so then offering preconception care becomes a much more nuanced thing. And frequently things like, you've said if it happens, it happens. So that's where listening really carefully and then reflecting back what somebody has said becomes very valuable. So since you've said if it happens, it happens, would you like to discuss ways to be prepared for a healthy pregnancy? The only other thing I want to point out about preconception care, notice there's no word plan in here. And that's so important, because remember Sonia Barrera's study that I was talking to you about earlier, the word plan would definitely put someone off of the idea of preconception care. If I said to somebody who firmly believed that they were not allowed to plan a pregnancy because they neither had their finances in order nor did they have a partner, yet they were perfectly open to pregnancy, it was perfectly acceptable to them. If I say to that person, let's talk about preconception care because you're planning a pregnancy, or because you know, clearly you're having unprotected sex, so you're planning to get pregnant. All these types of words can be triggering. So that's why we came up with this phrase, would you like to discuss ways to be prepared for a healthy pregnancy? Because everybody wants a healthy pregnancy. There's not very many things you can assume about your patients. I would ask you not to make assumptions as much as possible, to refrain from making assumptions, but you can assume that people want a healthy pregnancy. You can assume people don't want to live a life of pain and disability. That's something you want. You can assume people want healthy pregnancies. So asking, would you like to talk about ways to be prepared for a healthy pregnancy, really is aiming to fill that gap that exists when somebody is not actively planning something, but they are in fact open to that thing. Remember the definition for plan is that you actually take concrete steps. So if you cannot make concrete steps if you're not planning, this is a way to allow someone to actually make a concrete step without having any commitment to a plan. So I'm going to repeat that. This is a way, the whole concept of this is a way to allow someone to have the services, the preconception care services, without having any plan or intention in place. And it may sound a little bit contradictory because we don't normally do that in medicine, but reproduction isn't really actually a medical thing. And then what about your patient who is medically complex? You want to be able to individualize the timing question. Okay, so I wouldn't just say, Samila, do you think you might like to have more children at some point? And she says yes, and I wouldn't then just say, when do you think that might be? I'm going to take this opportunity to give my strong medical recommendation. And this is part of your job, is to, in addition to helping someone clarify what they want, there are, in some cases, right answers. Only from, not the right answer meaning Samila should do this thing and shouldn't do that thing, meaning that somebody who has diabetes, there is better outcomes if their diabetes is under control than if their diabetes is not under control when they're pregnant, right? That's a right answer. There's a medical right answer here. It doesn't mean Samila is going to make the choice that is going to be consistent with that, but we want Samila to know the information. We want to help Samila integrate the information, and we want to help Samila have what she wants with her reproduction, right? But remember, one of the things she wants is to have a healthy pregnancy. So it's important to start by saying, so I've said to Samila, do you think you might like to have more children at some point? And Samila says, absolutely. And you say, well, it sounds like you'd love to have another child at some point. So in other words, you're reflecting back what you heard. And then you're going to give your strong recommendation. It's important for people with diabetes to be prepared for a healthy pregnancy by getting their blood sugars in good control and making sure they're on the right medicines before they get pregnant. Knowing that, and that's a good thing that you always want to do, give one piece of information followed by a question, okay? And this is an example of doing that within the PATH framework. So knowing that, since you've said you'd love to have another child at some point, when do you think that might be? So in other words, you're not telling Samila, don't get pregnant. You're saying, here's the information about getting pregnant, and knowing that information, what are you thinking? Essentially, that's what you're trying to get with your patients, is what are they thinking? And here's the question that we're calling the best question, but that Blondine says is not going over very well. But do you have a sense of what's important to you in your birth control? And I want to just back up 2 seconds, explain it, and then we're going to go ahead and do our role plays for you folks. So do you have a sense of what's important to you in your birth control? It's a very specifically thought out question that actually I didn't put the reference, but Christine Dellendorf, who's she's pretty much the main contraception counseling researcher in the United States. She came up with this question because the question we always ask is, what birth control method are you interested in? So imagine that question, what birth control method are you interested in? That question presumes, A, that the person knows enough about birth control to give you a cogent answer, which is probably not true in the vast majority of cases. Because if you think about how much each of you know about birth control, and imagine the things that you don't know, that you've learned that you don't know, and that you need to know and you want to know. Imagine that there are still gaps in all of our knowledge base about contraception, even when we're pretty knowledgeable. Now think about your patients. They are not knowledgeable, so imagine the gaps in their knowledge base. So A, they don't have enough information to really answer that question. B, they may feel when you say, do you have what birth control method are you interested in? They may feel put on the spot like they have to give you an answer. They could say, I don't know enough about them. They might say that. But they also are likely to say whatever it is that they do know, or whatever it is that they think you might think they should say. Hopefully none of you are having that happen a lot, but we know that with patients, they say what they think we want them to say all the time. Like, unfortunately, according to studies, most of the time. So we're trying not to have them do that. So we're trying with this to get away from talking about a specific method as much as possible. We're trying with this to get a sense of how the person feels about each of the things on this list. And the things on the right side of the list, effectiveness, hormones, length of use, control over removal, object in the body, and return to fertility, all of those things are things that if you're having the conversation within the PATH framework and you're asking the PATH questions, and then you're asking, do you have a sense of what's important to you in your birth control, these will get answered anyway. It's the ones on the left that you probably need to query about proactively, especially how do they feel about their menstrual cycle? What kind of bleeding profile are they interested in, and why? So what you would say, you already know that if you've asked the PATH questions and the person, if you say, how important is it to you to prevent pregnancy until you're married, this patient that we just spoke to earlier, if the person had not answered, well, if it happens, it happens. If the person had instead answered, it'd be really important to me not to get pregnant. It's one of the most important things to me. Then you can go ahead and say, once you're talking about contraception, you can say, it sounds like one of the things that's important to you is that your birth control is very good at preventing pregnancy. Because, you know, that's a characteristic of birth control. Not all of them are highly effective. That's why there's a tiered effectiveness chart. So if the person's not particularly interested in effectiveness, then you wouldn't say this. You would just say, do you have a sense of what's important to you about your birth control? But in this case, if the person has told you that it's really important to them to prevent pregnancy, then you can make that leap and say, it sounds like one of the things you're looking for in birth control is that it's really good at protecting you from getting pregnant until you're married, until Johnny is 2 years old, until you're out of school, whatever it is. So let's go back to this. I want to break down this. Blondine, you had an experience with your patients, you said, of having them sort of not know what you meant and say, what do you mean? And Jamie talked about giving examples like this. For example, some methods have other things that they can do for you besides just being birth control. They can help with acne, or they can help with your period cramps. Is any of that something that's important to you? That's the kind of example you might give. Or, for example, some methods of birth control change the way your periods come and others don't. Is that something that matters to you? Some methods of birth control, for the most part, you don't get any period at all. And some methods of birth control, they help make you do still get a period, but you can schedule when that happens. There's all kinds of ways you can say this, but you're going to want, exactly like Jamie said, to use your example of what I mean is, for example, some methods do such and such, or some methods do such and such, based on the individual that you're talking to. So let's go back to this question for a moment. Do you have a sense of what's important to you in your birth control? If the person hesitates, now this may seem a little detailed, but Blondine, you're not the first person who has had this issue with patients initially with this. There is a little bit of finessing. So if you ask your patient, do you have a sense of what's important to you in your birth control, and they don't come up with an answer, give them to the count of 5. This is where you want to apply just a little bit of silence. Just give them a minute to think about the question. And this is true in general when you ask a question that's open-ended but focused. Give them a minute to collect their thoughts, to collect their response before jumping in. So one thing to do is wait up to 5 seconds. Very difficult to do that, but just go ahead and count to 5. Another is to leave off the do you have a sense. You could say, if the person's not getting it, essentially, you could say, what's important to you in your birth control? For example, are there things that you like about birth control you've had before and things you didn't like? Or you could use that as your example. You know, you could say, what's important to you in your birth control? Or you could say, what are you looking for in your birth control? That's another thing you could substitute, looking for or important to you. So if Blondine, if important to you doesn't resonate for your patient, you could say, what are you looking for? But don't rush in with examples until you've given that 5 seconds to let the person consider the question. I'm going to go back to the past question so that we can do a little role play. Boom, 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 boom. So, Jamie, can we start with you?
Of course.
Okay. And Jamie, I'll be the patient the first time, and then if you could be, I'm sorry, I will be the provider the first time, and then if you can be the provider the second time, that would be great.
Sure.
Okay. So you've already got your person prepared, right?
Mhm.
Okay, great. Just tell me your age and if you have any medical problems.
I am 33 and I just have a little issue with fertility.
Okay. What is your issue with fertility?
I had to do clomidine to get pregnant.
Okay. Great. And how many kids do you have?
1.
So, do you think you might like to have more children at some point?
Yes, definitely.
You sound pretty clear about that. And what I could also do, by the way, for those of you, not Jamie or me, but everyone else, if you hear those words, imagine you're not just hearing the actual words, you're also hearing the tone of voice that she's giving us. She was very happy about having another child. There was a positive vocal tone. This wasn't her saying, yeah, I think so. She said, yeah, absolutely. So that makes a big difference. Pay attention to the attitude that's coming out, both in the vocal inflection and the facial expression. We can't see Jamie's face right now, but she's possibly having a lighted up face and she's leaning forward, and as opposed to if she was leaning back and crossing her arms and seeing, like, don't let another child ever come through this vessel ever again, even though she says yes. So you have to, I think the whole picture is what we're looking for. So, well, it sounds like you're really excited about that. When do you think that might be?
Definitely not for another year or 2 at least.
Yeah. And how important is it to you to prevent pregnancy for the next year to 2 years?
I mean, it would be amazing to wait that long, but I don't know. I think with my history, if it happens, it happens.
Mm-hmm. Yeah, that seems, I hear that a lot, and that seems really, like, makes a lot of sense. So given that you don't want to necessarily be pregnant, even though it would not be the end of the world, in fact, it sounds like there's some amount of, there's some way in which that would also be great for you if it happened a little sooner. But given that you don't actually want to be pregnant in the next year or 2, would you like to talk about birth?
Yeah, I would.
Okay. And do you have a sense of what's important to you about your birth control?
I definitely know I don't want something that would prevent me or prolong me from getting pregnant again. And I think I don't want anything in my body, if that makes sense.
Mm-hmm. Mm-hmm. Yeah, I hear that a lot. Okay, so I'm just going to step out of the role play for a minute. She's given me 2 things. I'm going to respond to the 2 things separately. And I'm not going to jump on filling in. This is a really important point, is I'm not going to jump in and give her the responses to both of those things at once, because it's too much information. Okay, so I'm going to break them down. So for the first one, yeah, I hear that a lot. A lot of people feel like they're concerned that using a birth control method can delay their ability to get pregnant, or that their ability to get pregnant could take a while to come back to whatever's normal for them. Now, also, I'm going to step out of the role and say, when you talk about anything to do with fertility, return to fertility, or challenges with fertility, a really nice expression is your ability to get pregnant goes back to whatever's normal for you. So your ability to get pregnant going back to whatever's normal is a really important phrase, as opposed to fertility or any other ways that you could think of that are really medical-y kind of things. So I do hear that a lot, and luckily, there's really, you're right that there are some methods, like the shot, that it can take a while for your ability to get pregnant to come back to whatever's normal for you after you stop using it. But for the rest of the methods, your ability to get pregnant goes back to whatever's normal for you immediately when you stop them. And when you say, so normally I would want to follow that with a question. I'm going to, for the sake of time, I'm going to go to the next point that she said. And I'm going to say now this is an open-ended question for her, and it's kind of like, it's giving time for pause. So go ahead, and if you wouldn't mind, Jamie, just for the sake of the learning point, say the point again about you don't want anything in your body.
Yeah, I don't think I want anything like in my body or anything like that.
And when you say in your body, now see, what I'm doing with her is I'm not rephrasing the entire question or rephrasing her entire statement. I'm just giving her I'm prompting her to talk more. When you say something in your body, you mean, or I could go further and say, explain to me what you mean by that.
Yeah, I don't think I feel comfortable having anything inserted inside my body. Like there's that T-looking thing, or the stuff that goes in your arm. I don't think I like knowing something's inside my body.
So it's the idea of, that's what it is that concerns you about it. It's kind of like the idea of having an object in your body that's not natural.
Yes, definitely.
I'm going to you want to query this, and what I don't want to do with Jamie right now is to say, why on earth wouldn't you want something in your body? You've got braces, you've got fillings, you've got knee replacements, people use all kinds of stuff. I will want to point those things out potentially, but I don't want to start by saying why. I will want to ask her, though, a very similar question. It sounds very similar, but it's not the same. If I said why, how would that feel for you, Jamie? If I said, why wouldn't you want to why don't you want an object in your body?
It could feel like you're attacking. Yeah, it feels like you're attacking, attacking or questioning my choices.
Yeah. So I think one thing that we can do in that situation to be a little bit, to not feel like you're challenging someone. Can you tell me what's concerning to you about having an object in your body in that way? I mean, people, like we have all kinds of medical devices, like people put new knees in their knees. Curious what it is that's concerning to you about that.
Oh, I mean, I didn't think of it like that. I feel like just with birth control, it just seems like, oh my gosh, it's so permanent, putting something inside and leaving it there for years. It just seems, I don't know, it just seems weird.
Yeah, I hear that all the time. People often think that because a birth control method can work for up to 10 years, that somehow that means it's supposed to. I hear that all the time. So do you see how I'm giving her a yes? I'm validating what it is that she's saying, and then I'm also adding information subtly of you don't actually have to use it that whole long time. I might at that point say something like, any of those methods that you're talking about can be used for as little or as much time as a person wants. In fact, if you wanted to use it for even 9 months, it'd be really, really good at keeping you from getting pregnant for 9 months. And as soon as you stop using it, and if you want it out for any reason, just come in, we'll take it out for you, and your ability to get pregnant goes back to whatever's normal for you immediately. So I'm just I'm doing this very quickly to just show you sort of an example of how you might respond to that. Okay, so Jamie, are you ready?
Mm-hmm. Yes.
You're going to be you. I'm going to be
Okay.
a mystery. You don't know who I am. Okay, so I'm 22 years old.
Okay.
And I have 2 kids.
Okay.
And I have lupus.
I'm sorry, you had what?
Lupus.
Lupus. Oh, got it. Perfect. Okay. Hi, so do you think you might like to have more children at some point?
Oh, wow. Yeah, I'd love to.
Okay, well, I'm hearing that, yeah, you would love to at some point. When do you think that might be?
Oh boy. No time soon. I would like, right now I'm doing really, really well with my lupus.
Mm-hmm.
So I feel like right now I want to have more kids. I don't know. I don't think anytime soon.
Okay. Well, I mean, how important is it then for you to prevent pregnancy until then?
And I made it difficult for Jamie because I did not give her much of anything, but I gave her a hint that what I was concerned about was my health. So what that gives you an opportunity to do, this is quite advanced, but what that gives you an opportunity to do is to give me some positive feedback for the fact that I'm considering my own health and what's best and those sorts of things. So mirroring that you get it, that I'm being responsible in this. I am a 22-year-old with 2 kids, and I am concerned about my health. So at some point, that is something that you do have as an option. You know what? It is really important to me. Yeah, it is. It's really important to me.
Well, I mean, that sounds great. It sounds like you're definitely concerned with your health, and it's important for you to want to feel better with your lupus, that you want to go ahead and prevent pregnancy. Would you like to talk about your birth control options?
Yeah, I'd love to.
Perfect. So what do you have a sense of what's important to you about your birth control method?
So Jamie, did I give you any indication from what I already said about a characteristic about birth control that I might?
Yes, I mean, so it sounds like it sounds definitely like, with your health is definitely an importance to you. Is there anything else about your birth control method that would be important?
Just for everyone, there's when we ask the PATH questions, the third question, how important is it to you to prevent pregnancy, gives you information about contraception. Or it doesn't. Sometimes it doesn't. But if it does, it tells you how they feel about effectiveness. So what I also want to clarify, that second question, the timing-based question, doesn't really tell you much of anything about which method. Somebody can say, I don't want to be pregnant for the next 18 months, or I don't want to be pregnant for the next 7 years. It doesn't matter. Any of the birth control methods can do that for them. It doesn't matter how long. But what does relate to birth control is, how important is it to prevent pregnancy? I said it's really important. So you can say, it sounds like one of the things that's important to you about birth control is that it's really good at keeping you from getting pregnant until you're ready, or until whatever time. So that's what I meant when I said, is there something I told you already?
Oh, got it.
Do you want to go ahead and do that, and then I'll give you your response? Just
Sure.
for the folks.
Yeah, of course. So it sounds like preventing pregnancy is really important to you. Do you have any other sense of what your birth control method is important for as well?
So just so you guys know, one of the main things that patients are misinformed about is that not all birth control methods are equally good at preventing pregnancy. That's why we have those 3 tiers in the tiered effectiveness chart. I'm just going to pull it back up again. But that's why this tiered effectiveness chart is really helpful to have in your bag, because if you look at the top tier or the top 2, the number of little pregnant bellies on the right is sort of a pictorial indication of how effective they are. So if I don't know that any of these methods are more effective than any of the other methods, then that's not a characteristic I'm going to talk about. Because I'm going to assume, a lot of patients assume if you're giving them this as an option for birth control, then it's really effective. And a lot of patients believe if you're on a method, any of these, that they're all going to work 100%. It's just when you don't use them that it doesn't work. And so, they're not 100% wrong. This is a tiered effectiveness chart based on typical use. It is true that all these things in the green second tier would be top tier if people were perfect in their use, or close to top tier. They may be a little less than 1% failure, or a little more than 1% failure, but not much. It's the typical use that makes them that way. But nonetheless, there are stark differences between the effectiveness of an implant and the effectiveness of something in the second tier, and certainly from something in the third tier. The implant, by the way, is the most effective method. It's like 1 in 10,000 people using it will get pregnant. As opposed to an implant, an IUD, where it's, would be maybe 1 to 2 per 1,000. So, and even close to, close to 1 per 100 if you're the copper IUD. So so when I talk about characteristics of birth control, one of which is effectiveness, it's talking about the birth control method itself, its inherent effectiveness is something I'm seeking. So what I would want to hear, if I were the patient, what I would want to hear is that I'd want you to frame for me that I'm looking for a birth control method that's really effective, but use patient-centered language. So one of the things I'm looking for in birth control is that it is one of the things on this list that works better than one of the things on this list that doesn't work well. And that's why I'm differentiating what you had said to what I'm talking about with effectiveness, because you want to take every opportunity possible to let the patient know that not all birth control methods are equally effective. Anyway, long-winded answer. So you want to do that again?
Sure. Okay, so it definitely sounds like preventing pregnancy is very important to you. Here is the sheet that actually shows options of birth control that are very highly effective. And as you can see here, and then I would pull out the sheet or our book, whichever resource I had to show you. And I would show them your options that you do have. And then I would ask them if there was anything that they might have questions on or be interested to talk about these options.
Great. And then you could ask me, do I have a sense of what else is important to me? I don't even know what I can use for birth control, because before they told me I could only use condoms.
Oh yeah, no, actually, and then I would actually pull out my device. So I would pull up the CDC menu and for the systemic lupus and say this is a great resource that all health providers go with, looking into information available for contraceptives available. And looking at this chart, it looks like with lupus, the IUD, the copper IUD is actually safe, very safe for you to use with your lupus. And it is definitely on the highly effective options you have available to be able to prevent pregnancy.
That's great. I don't really want to put that's that thing that goes inside my uterus, right?
Yeah. So this would be something that your doctor would have to put inside of you.
just to point out for the U.S. medical eligibility criteria, lupus is a really important one for everybody to get familiar with. Not familiar with all the answers, just familiar with how to get, like, where to go on the app to find it. Because as you notice, the things that contain estrogen are a 4, but a lot of the other methods that are top tier and well, top tier and then the injection for the second tier, but the top tier methods, there's no 4s. You notice that there's 3s, and those 3s, if my lupus is controlled, if I'm on medication and my lupus is doing well, I don't even have top tier methods that are 3, so I could actually use an implant or a hormonal IUD also. So while you'll notice in the medical eligibility criteria, the copper IUD is frequently the thing that has a 1 when other things have 3s and 4s and 2s. That doesn't mean that the other methods that are these, if I have positive antiphospholipid antibodies or not unknown, and I'm not on medication for my lupus, then they're a 3. But a 3 is still not a 4. Remember that, everybody. I want you to remember. And she's got lupus. That's not okay, right? She should not get pregnant. I mean, from a medical perspective, she should get pregnant when she's in good shape medically. So anyway, that's just, I gave you a complicated one just because I knew you'd handle it. Okay, Blondine. You
Okay,
ready?
Patty, can I have a suggestion about the lupus as well? One question I would have asked was what was her mother's knowledge about her condition and what she had been told as far as birth control in the past by her doctor.
I think it's a great, yeah, that's great.
I would have, you disagree?
No, I said that's great. I think that's great.
Oh.
There are so many different.
Because we need to know mom's knowledge. We need to know mom's knowledge about her condition.
Yes, exactly. And what you want to do with that, I mean, I think that's a very important point. And what you want to do with that, remember I said about how give her positives for it? As much as possible with all of the visits that everybody's doing, I'm sure you do this already, point out positives. Point out things that the person knows that are correct. Point out things that are when the person's doing something that was challenging or that was really effective. Just pointing that out all the time. And this is a perfect opportunity to point out that, wow, you've got 2 kids and you've got this, you're struggling with this and you're doing so incredibly well. It's you know, it's remarkable. So I agree with you, and I also think it's an opportunity to pivot that to something as a positive. I think just telling somebody positives as much as possible builds rapport. So are you ready? Do you know who you are, Blondine?
Indeed.
You know yourself. How old are you?
Well, I'm past reproductive
Blondine's
age,
pretending to be somebody, just on the note.
So I'm going to pretend it's me like 30 years ago.
Okay, how old are you? The person you're pretending to be?
Pretending it's me? Okay, I'm 35.
You're 35,
and I have 3 kids.
Do you have kids?
I have
3 kids?
I have 3 kids.
Okay. And do you have any medical problems?
Nope.
Okay. Do you think you might like to have more children at some point?
Well, I'm super ambivalent about this. I'm really not good at birth control. So
I hear that a lot.
I know I should not. I know I should not because I'm not in a good marriage. However, it's very hard for me to close the chapter of maternity.
Wow, it seems like you've really thought about this a lot. It's complicated, isn't it, grappling with all these? So here's the thing about Blondine right now. If you are pretending to be yourself, I don't know what folks on the call think, but that was a very, that person who's giving me those answers has thought about this a lot. I would be extremely positive in my way of approaching you and very impressed that you had given this so much really deep introspective thought. And I mean, the reason I'm saying all this is I don't know how beneficial this will be for folks to listen to it, because you're already so introspective and so in touch with yourself that mostly what I would be doing in that case is just trying to see how can I help. We can play this out if you want to,
exactly,
but I think you're pretty advanced. The patient's very advanced.
How would you? I disagree with you. I think it would be very important to, how do you conduct an interview like this? What would you say?
Okay, let's do it. I just think you're being awfully smart. Do your patients, I mean, do you think that this is a patient that somebody could actually run into in your real life?
Yes.
Let's do it. Okay. Wow, it sounds like you have given this a lot of thought. I don't often hear people that have been that introspective, and it's moving. And I can see how it's a difficult situation for you.
It's very difficult.
Yeah. So how
because
important is it to you at this point to prevent pregnancy?
My husband, he won't use condoms, and I'm reluctant about birth control. I don't know what to do.
So how important is it to you to prevent pregnancy at this point? Given all that. See how what I'm going to do at this point, I say given all that,
it is very important to prevent pregnancy.
It feels very important to you?
Correct.
So
because I know
even that you don't
have another child.
When you say you shouldn't have another child?
Because I'm not in a good marriage. I have already 3 kids who are healthy. I'm 35 years old, and intellectually, I understand I should not have another child. This is not a good situation to bring another child. However, I don't know. I'm super confused.
Yeah, I can hear that. It sounds like a really confusing situation. But again, you really sound like you've given it a lot of thought, and it's wonderful to see that you've really grappled with this. So, given that it's really important to you to prevent pregnancy, and that you don't want to be pregnant at this point anyway, given all that, would you like to talk about birth control methods, contraception options for that?
Yes, very much so.
And it sounds like one of the things that you're probably looking for in birth control is that it's really good at keeping you from getting pregnant. Do I have that right?
Yes, absolutely.
Do you have a sense
what
of what
else would I use birth control? If a birth control is not efficient.
I know, I hear that from people a lot. But, I think a lot of people don't realize that not all birth control is that effective. So do you have a sense of what else is important to you about birth control, about your method?
So, I mean, hormones, I hear that after 35, it's not recommended to take hormones. Is that true?
Wow, you really are knowledgeable. It's amazing. It's true. It is true that when it comes to one of the hormones that's in birth control, it's not safe if somebody smokes and they're over 35. Do you smoke cigarettes?
Well, I smoke like 2 cigarettes a day.
Okay. If it's truly only 2 cigarettes a day, then you are really, if you have no other medical problems, then really you can use any birth control method you like. Yeah, no, you're in the lucky position of being able to choose absolutely anything on this entire chart.
Okay.
So do you have a sense of what you're looking for? Like some methods can help you with period cramps, and some methods are things you don't have to ever worry.
What I have is I have a tendency to have heavy bleeding. So I'm worried about IUD because I hear that the first 3 or 6 months you get heavier periods.
Oh, well, that's one of those wonderful things to offer for you with birth control is it can help with your bleeding. So that's actually I'm happy to hear that there's something other than just being able to keep you from getting pregnant that birth control can do for you. And you also said that you felt like you weren't great at being able to take you know, remember to take birth control, which, believe me, none of us is very good at being able to remember, for example, to take a pill every day or something like that. That's pretty challenging for human beings in general. So is that also sounds like it's something that you're interested in, something that you don't have to think about?
No, actually, I'm super scared of having any procedure having to do with insertion. So I would rather take a pill every day. If you're telling me like my 2 cigarettes a day, it doesn't matter. And it seems like you know what you're talking about.
So just for everybody on the call, so Blondine, because she knows about the methods, she's going to procedural things. She's going to, this is a device. When you're talking to your patients, maybe they'll know that and they'll go there, but we in our conversation, Blondine and I are not yet at the point where I would have talked about methods. I want to keep talking about what characteristics she's looking for, because right now she'd like not to have to think about it, as long as obviously she's getting that this is tied to a device. But let's say she didn't, then she's already said she doesn't remember. You know, she's not a good. She called herself a not good contraceptor. I wouldn't call her that, but she did. She wants something effective. She wants something for heavy bleeding. No, you didn't. No, you didn't. You didn't say bad contraceptor, but you said I'm not good at it. But I wouldn't say that.
Can I interject real quick? It's 7 minutes past 10, and I just wanted to be aware people are starting to leave the webinar. Just wanted to be respectful of everyone's time. This was scheduled till 10, but we're happy to keep going for people who can stay.
I have a visitor.
So just wanted to.
I thought we were going till 10:30. That's right. We're 8:30 to 10. I'm so sorry I messed up the time like that. Okay, we can be totally done. Let me just see if there's anything on here that I wanted to be sure we got for you. I don't think so. Yeah, the only thing I wanted to say is that and I'm terribly sorry for messing up the time. When you're going to correct somebody, doing something positive first and then correcting them, or then giving them the information would be great, and starting with either an empathy statement, validation, or agreement. That's the only thing I wanted to leave you with. And then following any question that you ask, any piece of information you give, follow with a question. And so that would be one of these kinds of questions. So those are really the important things I wanted to say. And thank you very much, everybody. I'm sorry for the time mess up. It's because I got on at 8. I was thinking an hour and a half after 8. I mean, yeah, I'm sorry. 8:30. Never mind.
Well, thank you, Patty.
That's
never
fine.
mind. I was off by a half hour.
That's okay. I will include all your slides so everyone will have the information that was not included. Thank you so much, Tanya, Blondine, and Jamie for being, such willing participants. And thank you, Patty, for sharing this information. This webinar is being recorded, so we will put it on the blog along with any other resources that Patty's provided for us. So if you have any questions, I know we went over, please email me and I can pass them on to Patty, and we can send them out with the notes, pass on the answers with the notes. All right, thank you all, and thanks for your patience, and we really appreciate your attention.
Thank you, Malika.
Of course, have a great
Thank you so much, Blondine and Jamie. Thank you.
You're welcome. Goodbye.
Okay, take care.